So the objective today in the next 15, 16 minutes is to evaluate strategies that employ to shorten duration of treatment from 8 to 12 weeks. Because the standard of care is 8 to 12 weeks, we are going to talk about how we can actually shorten the duration where the data is. I will be talking about 3 different sets of data. One, initially, what's the scientific rationale to do this? I will go through that in the beginning, and then we'll describe the studies that have conducted so far, some of them been alluded to earlier. And finally, we'll try to close by suggesting what exactly an ultra-short duration of treatment is going to be applicable today. As today means we have treatment that's freely available, generics are available globally, which populations would benefit, and why should we pursue an ultra-duration treatment? So the scientific rationale starts with the mechanism of clearance of hepatitis C. It's quite simple because you only have one reservoir of infection, which is the hepatocytes, which get infected with hepatitis C virus, and a particular rate virions are secreted into the plasma, and these virions will catch up to uninfected cells, and there exists a balance between these that determine what your set hepatitis C viral load is. So the directly acting antiviral agents, you block one thing, and they block the production of hepatitis C virions. That's the only thing they do. It makes it extremely easy to look at this mechanism. So if you assume that DAAs have 100% efficacy, that means they can block hepatitis C production in every single infected cell at the 100% of the time, no virus is coming out. And that means that all you have to do is to wait out for all the infected hepatocytes to die out, and that will determine your duration of treatment. But we know that that is actually not the case because no drugs are going to be 100% efficacious, and there is always room for increasing potency of that. The entire basis of ultra-short duration is come from this hypothesis, that if you believe that drugs are already 100% efficacious, then there is no more room for us to go. The second aspect of it is that we always have to assume that there are things happen. If the DAAs are not 100% efficacious, there is still going to be some virions that are coming out, and they are usually taken care of by host immune responses. Host immune responses are not quantifiable because we look at different variety of different things, and we really cannot assume how much of this quantifiable responsible is happening in different circumstances. One thing we can for sure is that as we increase the potency of the DAAs, and you're going to rely less and less on host immunity. And that's exactly what we for sure. The first thing with the study they did, and Nida Kohli somewhere in the audience did this study called Synergy, where we added a third drug to Harvoni, which is sulfosporin ledipasvir, and try to look at viral kinetics as a modality to look at in vivo efficacy of synergy between these molecules. As demonstrated here, if you add a non-nuke or an NS3 protease inhibitor, you can actually have an impact on HCV viral kinetics, thereby demonstrating that you can increase the potency by adding a third agent. It was the first step. The second step, again, was presented in Hep DART before, is just to look at whether if you increase the potency of DAA, would that, previously I said that we can rely less on host immunity. For that particular study, we looked at interleukin 28B-CC haplotype. Interleukin 28B-CC haplotype is probably the most simplest way of quantifying host immunity in an individual for hepatitis C. We know that people with interleukin 28B-CC haplotype tend to have better responses. They have better clear HCV, are more likely to have spontaneous clearance of hepatitis C. So it reflects a good antiviral immunity in a host. Here is shown in a single DAA study. We looked at whether interleukin 28B-CC versus non-CC patients have better virological response to cephalosporin and ribavirin. It's shown here that people who have the favorable good interleukin 28B-CC haplotype achieved better virological control. That means less time to undetectability or less time to achieve lower limit of quantification compared to the group of people who did not. Then it seems that host immunity did play a role in clearance of hepatitis C when you treat it with DAAs. But when you use the same data and look at the same data when patients use 2 DAAs, cephalosporin and ledipasvir, that means increasing the potency of the regimen, that kind of difference has disappeared. Same the hypothesis that host immunity does play a role. However, when you increase the potency of the DAAs, you rely less and less on host immunity to do that. So the next attempt what we did was we tried to understand how we can quantify immune response, because if you ask an immunologist, there are a variety of different aspects of the immune system play a role in controlling hepatitis. Not all of them are easily quantifiable, but most people can agree in a consensus that the CD8 responses is probably the most reliable in a chronic infection. So here if you expand peripheral blood lymphocytes and stimulate them with hepatitis C peptides for 48 hours, and then you can try to look at whether these the HCV specific cells are actually making cytokines in response to hepatitis C. In response to hepatitis C, if here you do a dilution of the study, you gauge on the cells that are alive, then look at these cells that are replicating in the presence of the dye. These are the cells that's probably replicating in the presence of hepatitis C, and then you can look at whether these cells are making specific cytokines. If they are making cytokines, they are responding to hepatitis C. That's a quantifiable fraction of a hepatitis C immunity. So again, you go back to the patient who received single DAA, so phosphorin ribavirin. You try to look at what happened to the host antiviral immunity as detected by as previously mentioned. You can see that the patient who achieved SVR really had a boost in its CD8 specific antiviral immunity, whereas the people who actually relapsed did not have an immune response. This tells you that not only this host immunity probably plays a role even in clearance of the last bit of hepatitis C, that is even in the presence of DAA treatment. What we did then is that we took these people who actually did not have a response and then treated them again with a 2 DAA regimen or it's a phosphorin ledipasvir. Then you increase the potency of the regimen. And then this is the old data. See what happened with those people. All of those people had better CD8 responses, saying that if you suppress the hepatitis C viral load, you're also going to have increase in host immunity because most of the effect on host immunity by hepatitis C is relieved, and the CD8 cells are actually relieved from the exhaustion, and they have better functional now. So not only you may have to rely less on the immunity, but you also have immune responses that favor you for clearance of hepatitis C. This has been demonstrated clinically. Tom O'Brien presented at last Hep DART that if you look at patients from ION-3 study, which is a phosphorin ledipasvir study for 8 weeks, and if you look at people who achieved SVR and you break down into patients who have low viral load and an interleukin-28B/CC haplotype, you can see they are enriched. Most of these patients were likely to respond for the 8 weeks of treatment. All of those patients responded if you have low viral load and interleukin-28B/CC haplotype. They're also saying that good host immunity predicts response to patients. The last 2 points I want to make is pretty straightforward. That you know that the longer you have to take the medication, adherence to medications drops. So here, this is demonstrated in the synergy study that we had, it's been demonstrated for the real life scenario. The longer you have to take, the people are not going to take. You're going to have pill fatigue. Even for a 12-week regimen, the number of pills you take, you're going to miss doses. And that's going to happen in the last few weeks of time. The easiest answer for doing short duration treatment is that it is probably going to reduce the cost. Regardless of what the cost is in flux. You really don't know absolute number of DAA treatment. It changes over time. It has gone down considerably, but it is in elementary school mathematics that if you have to take it for 1/3 of the time, the cost of medications will be lower. Not only cost of medication, cost of monitoring will be lower. So overall, you will end up being able to use the same amount of money to treat 2 to 3 number of patients overall. So that's the rationale of it. George Lau showed you the data of all the short duration studies done so far. There are several studies. To bottom line, most of the short duration studies have demonstrated that in non-cirrhotic patients for genotype 1, if you add a 3 DAA arm, you can reduce the duration from 8 to 12 weeks to 6 weeks. But if you do the same study, at least in most studies conducted in the United States, if you reduce it to genotype 1 patient, all genotype 1 patients to 4 weeks, the SVR drops. So 6 weeks is the limit. Beyond that, for genotype 1, we really could not reduce the duration of treatment. That's basically for non-cirrhotics. Non-genotype 1, it's more difficult to treat, and with the current DAA system, this has not been attempted to short duration treatment. So most of the short duration treatment we'll talk today is about genotype 1. So what have we learned from all these studies? What we've done from all these studies is that lower baseline viral load is a good sign. Genotype 1b is favorable. You can actually do the genotype 1b's response better. Absence of high resistant associated variants, particularly to NS3 and NS5A, are also predictive of good response to treatment. So this was a study George presented before. This makes my job easier. It's a SODAPI study, which is conducted by in Chinese patient population, which is a 3-week response-guided treatment. So basically what you did was the 3 regimens. So there were 3 regimens, which all had sofosbuvir. It had an NS5 inhibitor, either ledipasvir or decladisvir, and a acinaprevir or cimaprevir as a protease inhibitor. So everybody got 3 drugs, and at day 2, viral load was measured. It was less than viral load was less than 500. People were asked to stop treatment at 3 weeks. And as clearly demonstrated, even though there are quite variability in the beginning, all these patients achieved SVR12. So genotype 1B patients, you can achieve SVR if you add 3 drugs regimen. But that's very impressive that you actually are able to do that. So what do we do moving forward? Moving forward, we know that we are stuck, that we cannot continue with existing DAA regimens in genotype 1A beyond 6 weeks duration. But genotype 1B, there is already data demonstrated that you can actually move forward and reduce the duration. So one of the major criticisms that come up is that if we are playing around with all the DAAs for short duration treatment, thinking about the HIV era, we are going to build up resistance and make it more difficult for the treatment of these patients. That is necessarily not true. This is a study from Eleanor Wilson from our group in Synergy. The same studies have been done with all the short duration studies. The people who have failed the treatment have been retreated quite successfully. We have no problem in retreating these people, even with standard of care or some of the same regimens for extended period of time. So that has not been a major problem. So long-term complications because of emergence of resistance is not a major issue in this particular field. Then if you look at genotype 1B, even though we do not see genotype 1B in the United States, genotype 1B global distribution is quite huge. So you can see that Eastern Asian population, Eastern European population is predominantly driven by genotype 1B. Even though genetic medications may be available here in many of these countries, as George alluded to before, you can reduce the cost substantially and treat 3 to 4 times more people with the same amount of money you allocate for treatment of hepatitis C if you can design studies that will allow you to shorten duration of treatment for like 4 weeks. And we already have proof of principle in small studies that 1B can be treated for shorter duration. Second is the question of potency. So we demonstrated that increasing potency is possible. We already have DAAs. Do we really have the best NS5B? Do we have the best NS5A? We have the best, or there's still room to improve in the NS5A and NS3 class? Have you used the combination studies with the best combination? Or actually put together in a class to that, with looking at the PKs, do you really know which have the most efficacious combination? Or are there still room to improve? So what you clearly demonstrate here is that if you can increase this DAA potency, then you can reduce the amount of virions that come out of the infected hepatocytes. That will allow us to treat definitely shorter duration, even shorter duration than what we have right now. So if there are room to improvement on these medications, then increase the DAA, there are more room to grow to make a shorter duration regimen that's possible from right now. Just to show you the couple of studies that we've done. This is a study that was recently reported at the ASLD, but the Janssen study, they used the AL335, which is a nuke, along with the NS5 inhibitor, with a pan-genotypic agent with cimaprevir. And they treated patients 6 weeks and also with 8 weeks non-cirrhotic patients, genotype 1 and genotype 3. This is why genotype 3 is not a candidate for moving forward with shorter duration treatment, because it's always been difficult to respond to treatment. But genotype 1A, including the 1A, 1B patients, have responded quite well. So there are new agents that's available that maybe give us options to start looking at a more potent DAA regimen to explore short duration for genotype 1A. The other is that recently reported by Sam Lee and Rachel Nassi from Co-Crystal, a non-nucleoside analog that has been responded quite efficacious. If you look at this one, data, this is the first in human study that was conducted in Canada. They were able to demonstrate that there's a significant decline in viral load and a post-viral effect even after you stop treatment. If you compare the efficacy, antiviral, in vivo antiviral efficacy of existing non-nucleoside, this is usually 1 log. This particular drug is about 3 logs. So there is room for non-nucleoside analogs, so it may have a more potent agents that are available. And combination of those agents may allow us to shorten duration of treatment in the future. It has been extensively talked about that the people who drive hepatitis C epidemic globally are the people who inject drugs. They're also people who are not completely marginalized, and they're really not accessible easily. They're not engaged in care. They really don't go to see specialists. So we have been extensively talked by Margaret Hellard and Jason Grebley already here today that we have to reach out to them. And this is probably one of the places where short duration treatment is probably more efficacious. If you cannot control and treat people who inject drugs, we cannot really control and eliminate hepatitis C infection. That's the main concern. And as this is the data that's shown in non-urban and urban United States, hepatitis C infections prevalence is going down along with increasing use of injection drugs. So there have been studies looked at this. This is a recent study, some very small study that was reported last year from Denmark, where they actually used Harvoni plus ribavirin or Harvoni plus ribavirin with pegylated interferon, a strange design, for treated patients who are actively using people who inject drugs for 4 weeks. And they reported about 75% or 94%. Look at it, most of the patients were lost to follow-up. There actually only one failure in this study, small study. But these are the type of proof of principle studies we can expand on. And if you can do this successfully, incorporate this as part of the harm reduction strategies in harm reduction clinics without allowing patients to be distributed in different places, we have a better chance of eradicating hepatitis C. It was also touched upon the impact of incarceration in the United States and hepatitis C epidemic. This is a study from Jody Rich was published that tell you 20% of American population infected, but of the 10 million people in 2007 have hepatitis C. So about 2 million people actually are infected with hepatitis C. These people are not treated inside the prison or outside the prison. If you have, one of the major determining factor of people should be treated is the duration of incarceration. The shorter the duration treatment is available, we can have a better chance of making sure these people can be treated either inside before they're released or soon after they're released, allowing us to control the epidemic and the spread of the epidemic in the prison system. Since these people are coming in and out of prison into the community, integrated community without treated for hepatitis C, that's going to drive the hepatitis C epidemic. So that's another place where short duration treatment may have a major impact as a treatment of prevention methodology. So in conclusion, shortening treatment beyond 4 weeks in a targeted population is possible today. It's not possible for overall patients, but future studies will demonstrate whether such treatment will be possible. The factors that influencing the highest VR, shorter duration, are low baseline viral load, absence of high resistant RAFs to NS5A and NS3, genotype 1B, and having an IL-28B CC haplotyping being female. For all patients, the DAAs that are more potent or may have better half-life, longer half-life, will have to be studied in the future. And there is potential that this particular regimen could be quite efficacious in bringing strategies. Such coordinated global strategy will explore short duration treatment for hepatitis C is warranted. So just acknowledgement, this is our team, Eleanor Wilson on the hepatitis C team, and our DC program that Dr. Mazur talked about yesterday. Anita did most of the synergy studies. She's now relocated in Phoenix. Dr. Mazur for our support from the NIH and guidance for the treatment. Lisa did most of the immunological work. Thanks to George and Vanessa for sharing the SODAPI study, and Dr. Shinasi and Sam Lee for the co-crystal data, which is very encouraging as well. Anu did the SPARE study, and he knows for Gilead, obviously. Thanks for all the patients who participated. Thank you.